I'd like to invite our next speaker, Dr. Diane Lacaille. She's Senior Research Scientist at the ARC. She currently holds the Mary Pack Chair in Arthritis Research, Associate Professor, Division of Rheumatology, Department of Medicine, University of British Columbia. She practices rheumatology at the Mary Pack Arthritis Centre as well as Vancouver Hospital Health Science Centre. Dr. Lacaille completed medical school at McGill University in Montreal and her rheumatology training as well as master's at the University of BC. Widely published, she's received multiple distinction awards, and I'm not going to list them all, for her contribution to rheumatology research. And recently, she can also pin the Queen's Jubilee Medal on her lapel. So I could go on, but again, you can see that for yourself on the website. So please welcome Dr. Lacaille. Just use the arrows to move. Yeah.
Good morning, everyone. I'm going to talk to you about who is at risk of heart disease and why. And I'm hoping that this presentation will help you to evaluate your risk of heart disease. Because although we're saying here that risk of heart disease is increased with arthritis, it's not the same in everybody with arthritis. So we want you to be able to look at what your risk factors are and how it might affect your risk of heart disease. I'm going to talk first about what we call the traditional risk factors for heart disease. So those are the risk factors that are the same as in the general population. Then I will talk about risk factors that are more specific to arthritis. And finally, I'll talk about the effect of medications that are used to treat arthritis on the risk of heart disease. So the same things that increase the risk of heart disease in the general population also increase the risk of heart disease in people with arthritis. But what studies have shown is that those risk factors are often more common in people with arthritis. So if we take smoking, for example, it's been shown very clearly that smoking increases the risk of developing rheumatoid arthritis. And on top of that, if smokers get rheumatoid arthritis and they continue to smoke, they tend to have more active inflammation, more severe disease, and their arthritis is less responsive to medications that treat arthritis. So lots of good reasons to stop smoking if you have inflammatory arthritis. And this has been shown not only in rheumatoid arthritis, but also in lupus, and is probably true of all inflammatory forms of arthritis. Now, what about weight? Well, we know that having a weight above the recommended body mass index increases the risk of heart disease. And that is through increasing the risk of high blood pressure and affecting how the body uses cholesterol and sugars, such that there's an increased risk of diabetes and high cholesterol. Now, people with arthritis generally, on average, have a higher weight than the general population. And it's hard to know what's the chicken and what's the egg. So if people have pain in their joints and have difficulty exercising, they can be less active and it can be easier to put on weight. So it may be a consequence of arthritis. But we also know that being overweight is a risk factor for getting osteoarthritis. It's one of the few preventable risk factors of osteoarthritis. And once people have osteoarthritis, being overweight increases the progression of the arthritis. And in inflammatory kinds of arthritis, inflammation can change the way the fat is distributed in the body. For example, especially in men in rheumatoid arthritis, there can be a greater amount of visceral fat, and that's fat kind of around the belly, and that's the fat that's bad for risk of heart disease. Now, what about cholesterol? Well, inflammation can change the distributions or the kinds of fats that are in your blood, and it can increase your bad cholesterol and reduce your good cholesterol. And we know that higher cholesterol increases the risk of heart disease. Inflammation can also affect blood sugar because it can affect how it can increase blood sugar because your body cannot use the sugar as well because it's more resistant to the effect of insulin. High blood pressure, which is also a risk factor heart disease is also more common in some forms of arthritis. This has been shown in gout, in rheumatoid arthritis, and in lupus, especially if the disease can affect the kidney. We know that age and gender affects the risk of heart disease, so men and people who are older are at greater risk of heart disease. But what all the studies have very clearly shown is that the traditional risk factors, so those same risk factors that are the same in the general population, do not account for all of the increased risk of heart disease that is seen in people with arthritis. So the arthritis itself increases the risk of heart disease. And this has been clearly shown in rheumatoid arthritis and in lupus, but is probably true of all of the inflammatory forms of arthritis. And we think maybe as well in osteoarthritis. So arthritis itself, especially inflammatory kinds of arthritis, increase the risk of heart disease. But the risk is not the same for everyone with arthritis. The risk is greater the more active the inflammation. So people who have a greater number of swollen joints, people who have inflammation outside of the joints, so when people with rheumatoid arthritis, for example, can get inflammation in their eyes or in their lungs, and that increases their risk of heart disease, or people with lupus can get inflammation, can get affected in their kidney. So inflammation outside of the joints increases the risk of heart disease further. There are certain blood tests that are more common, for example, in rheumatoid arthritis, like rheumatoid factor or CCP. When this is positive, the risk of heart disease is greater. And when the markers of inflammation in the blood are higher, the risk of heart disease is higher. So I'm talking about something called the ESR, or sedimentation rate, or the CRP, which stands for the C-reactive protein. And studies have shown that the level of CRP in the blood is as strong a predictor of heart disease as your cholesterol. So inflammation is very important. And finally, the longer the duration, the greater the risk. And in rheumatoid arthritis, there seems to be a rise, particularly after 10 years of having the disease. And it may be that there's a cumulative effect of having inflammation over long periods of time that increases the risk. What about the effect of medications used to treat arthritis on the risk of heart disease? Well, first let me talk about anti-inflammatories, also called NSAIDs. And the greatest culprit there is the class of NSAIDs called the COX-2 selective anti-inflammatories. And this is why Vioxx, some of you might remember Vioxx, was pulled off the market, because studies showed that there was an increased risk of heart attacks when used in high doses over long periods of time. For Celebrex, which is the only medication in that class that is still left on the market, it has less of a COX-2 selective effect than the Vioxx, and there is no evidence of increased risk of heart disease at the doses that are used for arthritis. What about the other classes of anti-inflammatories? Their effect is a bit controversial. It seems that there definitely is not the same risk as with the COX-2 inhibitors. The main thing is that all anti-inflammatories increase the risk of high blood pressure. So it's really important, if you're on an anti-inflammatory, to be checking your blood pressure regularly. It can also worsen congestive heart failure. So if you have some heart failure, it can make that worse. So through these effects, it might affect heart disease. And the greatest concern may be with diclofenac, which is one of the anti-inflammatories, the one that's in Arthrotec. But there's also a concern with ibuprofen, which is Advil, which is the one you can get over the counter. And the main concern there is that if you are taking a baby aspirin to prevent your risk of heart attacks, the ibuprofen interacts with aspirin and takes away the preventive effect of the aspirin. So in general, anti-inflammatories are best avoided if people are at high risk of heart disease, or if while they're having active, for example, angina or chest pains. They can be used if necessary, but they don't have to be when the disease is well controlled. It's better to try stopping them. However, the greatest culprit in terms of medications is steroids or prednisone, and it has an effect on what's called atherosclerosis, which is the hardening of the arteries that causes heart disease. And prednisone has clearly been shown to increase blood pressure and to change how the body uses sugar and cholesterol so that it can cause increased risk of diabetes and high cholesterol. And studies have clearly shown an increased risk of heart attacks with steroids in people with rheumatoid arthritis and with lupus. And in fact, a study done here at ARC, led by Dr. Avina Zubieta, using the population of rheumatoid arthritis across BC, showed that people who were currently using prednisone had an increased risk of heart attack by 63%. Also showed that higher dose equaled higher risk, and that there was a 12% increased risk of heart attack for every 5 milligram increase in prednisone, and that longer duration of use equaled higher risk with an 18% increased risk of heart attack per year of past use. Now that's it for the bad news. What about the good news? Well, the good news is that effective control of the disease reduces the risk of heart disease. And the best evidence for this is with the use of methotrexate in rheumatoid arthritis. The landmark study for this that was published in The Lancet in 2002 was done by one of the ARC researchers, Dr. Choi, and he showed that use of methotrexate was associated with a 70% lower risk of death from heart attacks. And the protective effect of methotrexate has since been confirmed in about 10 other studies. And we think that this effect is through better controlling the disease because people who have a better response to methotrexate have a lower risk of heart disease. What about biologics? The anti-TNFs in rheumatoid arthritis have been studied quite extensively for their risk of heart disease, and most studies show that they have a protective effect on the risk of heart disease. And we did a study looking at the effect of biologics on mortality in rheumatoid arthritis and found a 75% reduction in the risk of death with the use of anti-TNF agents, and most of the reduced deaths were from heart disease. So in summary, I hope that this presentation will help you evaluate your own risk of heart disease. I've mentioned to you that the risk factors that increase the risk of heart disease in the general population also affect the risk in people with arthritis, and that people who are older, men, people who smoke, people who have a higher body mass index or higher weight, people with a higher blood pressure, high cholesterol, and diabetes are at increased risk of heart disease. But that the risk is not the same in everybody with arthritis, and that people with more active inflammation and more severe disease are at greater risk, and that the medications used to treat arthritis have an effect on the risk of heart disease. People should try to avoid steroids. They should minimize anti-inflammatories if they're not needed, and DMARDs, which stands for disease-modifying anti-rheumatic drugs or immunosuppressants in lupus, should be used to control the disease. Thank you.